So in continuation of our YouTube sessions every evening on our YouTube channel DAMS MDS Quest Club. Today I'm taking up the topic of retention and relapse. Before beginning, we're just waiting for the confirmation. Okay, so we'll start now. So good evening everyone once again. Myself Dr. Rijul Agarwal. I'm the orthodontic faculty at DAMS. So today, in continuation of our evening sessions on YouTube, I'm taking up the topic of retention and relapse, the most ignored topic of orthodontics, and few basic points about the removable appliances. I'll not be covering the functional removable appliances, just the basic removable appliances which we have done and the appliances we have made. Just a minute. Hello. ओके, मेरे को दिख रहा है इधर से पर हाँ जी ओके. So sorry for the interruption. So I'll just, as I said, I'll be covering up the topic of removable appliances, just the basic removable appliances which we have made during our graduation, third final year and internship. Okay, so beginning with the topic. So first of all, what is retention and relapse? Okay, the most common complication of any orthodontic treatment, post orthodontic treatment I meant to say, is to retain the results which what we have achieved. So what is relapse? Relapse is tendency of teeth to go back to their original position. Sorry. I'll just write it once again. Relapse is tendency of teeth to go back to their original position. And what is retention? Retention is basically to maintain the teeth at their most stable, functional and aesthetic position. Both the concepts of functional position and aesthetic position are important in retention. Okay, so today, and the third thing which is comes under this is stability. That the results which we have achieved should be stable. That the orthodontic treatment or the result which we have achieved for after working for however so once 1.5 year, we all know how long the orthodontic treatment takes up. That should be stable. So what are the factors which influences this retention relapse, and how can we retain our treatment using various appliances? We'll be discussing that. Okay, so beginning with the first top slide, that is what are the reasons for unstable orthodontic outcome. So what are the reasons? First is the developmental changes in the dentition over time. So as we all know, the teeth are in continuous stage of eruption. Once the permanent teeth have established, they are still undergoing attrition, abrasion, and they continue to erupt. The teeth have caries, so there is a mesial migration. So they are in continuous change or flux of change. That is also responsible for the relapse. Next is reorganization of periodontal and gingival tissues. The teeth is attached to the bone via the presence of certain periodontal fibers and gingival fibers. Now these fibers, once we have achieved a result, we often forget about the stability or the organization of these fibers, which contribute to the relapse of our orthodontic treatment. Next is the neuromuscular adaptation to the new occlusal scheme. Once we have achieved the new result, the occlusal pattern is also changes, or a new occlusal pattern is established. Okay, so the neuromuscular muscles, that is the nerves and the muscles supplying these teeth, should also get adapted to the new occlusal pattern, that is the temporomandibular joint. Should also get adapted to the new occlusal uh, new occlusion which is established, be it class 1, class 2 or class 3, whatever we have achieved. The TMJ and the neuromuscular muscles, that is the nerves and muscular supply, should also get adapted to the new occlusal scheme. Next, continued growth after the orthodontic treatment. Sometimes the treatment starts during the growth phase and ends before the completion. So the continuous growth or the growth period which is still remaining post our orthodontic treatment also leads to an unstable orthodontic outcome. Next is specific orthodontic tooth movements. Certain tooth movements, as we will discuss further in our slides, like intrusion, rotation, have a tendency for more relapse and are hence more unstable. Next, aging and late mandibular growth. The mandible, as we all know, is the bone which continues to grow sometimes post 18 years or post pubertal spurt as well, which can lead to orthodontic relapse or the crowding in the lower incisor region. Next, abnormal muscle behavior or oral facial function. Certain habits. What are this muscle or abnormal muscle behavior? That is habits. Now these habits are also responsible for this. Once we have achieved the without proper diagnosis, if we are doing the orthodontic treatment, like we are ignoring the fact that the patient still has an abnormal habit post our orthodontic, we have achieved the desired result, हमने अच्छी occlusion establish कर दी, we have corrected the spacing or any discrepancy which is present, but we have ignored the underlying cause for that malocclusion, and we haven't corrected that, will also lead to an unstable orthodontic outcome. And lastly, developing third molars. And why is there a question mark in front of it? Because this concept is no longer accepted. Earlier it was said that the erupting third molars leads to a lower incisor crowding, but this concept is still debatable and is nowadays not accepted, that erupting third molars can lead to an unstable or lower incisor crowding. That's why they have put a question mark and is hence the last. So beginning with the fibers. So firstly, during the orthodontic tooth movement, the trabeculae of the bone, as we all know from our biology of tooth movement, are resorbed and reformed, okay, parallel to the applied forces, and their reorientation takes approximately 6 months to complete. So whenever teeth are moved orthodontically, the periodontal and the principal fibers and the gingival fibers that encircle the teeth are stretched and contract and relapse. So the principal fibers of the periodontal ligament rearrange themselves quite rapidly in approximately 3 to 4 months of time. That is the principal fibers which attach the teeth to the bone. They realign or adapt quickly, whereas the collagen and the elastic fibers reorganize slowly and take time, and which contribute to the relapse of orthodontic treatment. So how much time do they take? So beginning with the collagenous fiber, they take approximately 4 to 6 months. Out of this collagenous, the elastic supracrustal fibers remodel extremely slowly and can exert forces capable of displacing a tooth even after an year. So they take, just note down this figure, more than 232 days to adapt to the new position. That is, the elastic supracrustal fibers takes more than 232 days to remodel or adapt to the new position. and the supracrustal fibers, particularly the transseptal fibers, are implicated as the major cause of post-retention relapse. Why? Because what are the transseptal fibers? These are the fibers which do not connect or do not have any bony insertion. They encircle the tooth from one teeth to other teeth. They just surround it and they don't have any bony insertion. So hence they take the longest to reorient after rotation correction. So how to avoid relapse in these cases? So when we do a severe rotation correction, it is recommended to do circumferential supracrustal fibrotomy or CSF. Okay, so it reduces now some technical or mathematical terms figure. So it reduces the relapse tendencies by 30%. Just note down these figures because they are asked as a MCQ in a NEET exam, and it is 30%, and this CSF was recommended by a scientist known named as Edwards. Okay, so basically to conclude, it is said that after comprehensive orthodontic treatment, 3 to 4 months of full-time retention is there should be done so as to allow reorganization of the periodontal ligament fibers. Okay, and the recommended protocol is that for at least 12 months the complete retention should be there, and thereafter it can be reduced to part-time and night time where so as to allow the other gingival fibers to readapt. And the latest or the current research says that lifelong retention is required because of these factors which I have mentioned, that is developmental changes which occur continuously in the dentition over the time. The human body is not in a stable change position. It's in the stage of constant flux or changes. That's why the latest concept says that there is a need for lifelong retention. But we do not recommend or say that to our patients before beginning the treatment. Okay, for obvious reasons. So it was a clinical thing. Coming back to our topic, so what are the different schools of thought process for retention? So first of all was the occlusal school. It was given by Norman Kingsley. He said that if after the orthodontic treatment there is a good interdigitation or maximum intercuspation, the results will be max stable. Okay. Next came the apical base school that was given by Lundstrom. He said that the mandibular incisor teeth must be positioned in relation to the basal bone so as to avoid there shouldn't be excess labial or lingual tipping. They should be present centrally within the mandibular bone. So how to ascertain that they are positioned in the correct position? So there are two other scientists who gave the concept of intercanine and intermolar width. He said that Macaulay said that the intercanine and intermolar width should be maintained and it should never be altered. The pre-treatment intercanine and intermolar width should be maintained. Next, Nance said that arch length should not be significantly altered. Pre to post treatment, arch length should not be significantly changed. Okay. Next came the mandibular incisor school. Okay, which was roughly similar to the apical base school, but he just tweaked in his concept. As we all know from the Tweed's analysis, he specifically said that the mandibular incisor should be upright and should be present upright on the basal bone. The mandibular incisor should be present upright on the basal bone. Okay. Next came the musculature school. Okay, and which is the last school of thought. It was given by Moyers in 1958. He said that there is a necessity to establish a proper muscle balance. So what is the proper muscle balance? That is basically the habits, the abnormal habits should be eliminated, which is the cause of malocclusion. The abnormal habits should be eliminated. Okay. So next comes the Riddle's theorems or the 9 theorems which Riddle gave. Okay. The 10th one, the last one, which was given by Moyer, which was later on added. Okay. So Riddle का नाम we have heard in during our cephalometry as well. It is the same person who gave the SNA SNB angle. Okay, so what are these 9 theorems? The first theorem is that the teeth that have been tend to return to their original position. Okay, why? Because of the musculature, the transeptal fibers, and the bone. Okay, very easy, nothing much to explain. Okay, next theorem, the elimination of cause will prevent the recurrence of the malocclusion. So what are the causes? Recurrence of the malocclusion. So what are the causes? So most common is the habits. Next is the hereditary means genetic tendency factors. Okay, next comes the local causes. What are example? Over retained deciduous teeth, nasopharyngeal obstruction. Okay, removal of these will correct our malocclusion. And lastly comes the congenital defects. Okay, which comprises approximately 2% of the all the cases. Third, overcorrection of malocclusion as a safety factor. Like what it means is that the teeth which are moved to position, they should be moved slightly further more, so that once the relapse occurs, the patient, the teeth return to the stable or the correct desired position. So this is a slightly controversial theorem because one cannot ascertain the amount of movement which is to occur. We can only say that we cannot ascertain how much relapse will occur. Okay, none of the orthodontic science till date has been able to determine or say that itna amount of relapse hoga. Okay, but nonetheless Riedel said this, and this concept of overcorrection, sorry, this concept of overcorrection was utilized later on by Roth when he designed his prescription. He gave up more tip and torque values than the desired because he said that relapse to hona hi hai. We'll move the teeth more further apart so that to prevent this relapse. Okay. Next, proper occlusion is an important factor in holding the teeth. That is maximum intercuspation. And इसमें दो concept आते हैं proper occlusion में, that is static and functional. Static is the one in centric occlusion, and functional is occlusion is the one during movement of the teeth, like chewing, speaking. Okay, that the occlusion should be stable at that time. Next, bone and the adjacent tissues must be allowed time to reorganize around the newly positioned teeth. So what are the times which we have already discussed? The principal fibers takes 8 to 9 weeks, gingival fibers 4 to 6 months, bone takes approximately 2 to 3 months. So we have to give respect to the time which is required for each of these things to reorganize according to the new position. Next, the lower incisors are upright and they are most likely to remain in good alignment. As I already said, they should be upright on the basal bone. So what is the basal bone? That is the alveolar process and the jawbone. Basically, it should be then that lingually positioned or slightly lingually tipped teeth are better placed. Now I have a question. Sir, any mnemonic to remember theories of retention? I'll just come to that. Okay. Let me complete the theorems. I'll just come to the mnemonic for that. Next theorem is correction carried out during growth less likely to relapse. Why? Because once the growth is completed, okay, the corrections are more stable. Theorem number 8, further the teeth have been moved, less likelihood of relapse. That's a similar concept to overcorrection. And theorem number 9, arch form cannot be permanently altered, which means, as I've already told, the intercanine and the intermolar width should not be changed. So as to have a stable relation. So these are the 9 theorems which were given by Riedel. So the 10th theorem which was given by Morris was that many treated malocclusions require permanent retention. What are these? Are arch expansion, generalized spacings, severe rotations, and midline diastema. We'll come to this concept of semi-permanent, permanent, and no retention in upcoming slides. So coming to the question which student has asked, that is a mnemonic for remembering this theorem, because n number of times it has been asked in NEET and INA exams. Match the following or identify which theorem is this. So this is a mnemonic which I have made. Former arch form, that is the first, is eliminated and overcorrected to get a good occlusion. Bone and upright incisors during growth move further and permanently. So these are the 9 theorems which I have summarized in one sentence for you to remember. Okay, bone, upright incisors over during growth period, the treatment carried out during growth have a more retention, less likely to have of relapse. The teeth which have been moved further, that is the overcorrection, and certain teeth require permanent retention. Okay, that is permanent. We cannot alter permanent leave is comprises of the, we cannot alter the intercanine and the intermolar width. These are the mnemonic for 9, helping you to remember the Riedel's 9 theorem to answer in your exams. Okay, former arch form is eliminated and overcorrected to get a good occlusion. Bone and upright incisors during growth move further and permanently. And just pick up words from each of these 9 theorems, one word. Okay, it's a part of remembering, trying to help you out to remember. Okay, I hope it helps you for your exam. So moving ahead, as I've already told you, Roth came with the concept of overcorrection. That is, in his prescription, we from evolution of appliances, straight fire appliances, first came the Andrews prescription, then came the Roth prescription, in which he overcorrected or gave us tip and torque values in his bracket prescription. They were increased because he said कि relapse तो होना ही है. So he overcorrected the tip and torque so that after the relapse they come up to the stable or position. Next, likewise, various scientists have come up with their keys of retention. We have done Riedel's, we have done Moyer's. There's another one scientist known as Rayleigh Williams. He gave 6 keys of retention. Okay, so what are these keys? That the lower anterior, that is the lower incisors to the apogonian line, should be 1 to 2 mm. The lower incisors apices should be distal to the crown. Okay, that is, they should be, the crowns are mesially tipped and the apices, that the root apices are distally tipped. And the lower left lateral incisors should be more distally tipped than the central to prevent crowding. Lower canines apex is distal to the crown. All lower incisor apices should be in the same labiolingual plane. So you have talked about in the mesiodistal, and from buccolingual or labiolingual plane, they should be in the same plane. That is, next, lower cuspid apex slightly buccal to the crown apex. The canines का जो apex है वो slightly buccal होना चाहिए than to the crown apex. And if possible, post treatment, the lower incisor should be slenderized if needed. Slenderized means slight amount of IPR should be done, approximately 1 or 2 mm. Why? Because to account for the late mandibular growth. Please note, it should not be done in all the cases. Based on our diagnosis, based on our treatment plan, this IPR is done. It is recommended to do slight IPR post treatment, so that if the late mandibular growth occurs, so when it occurs, there is less chances of lower incisor crowding. Okay, so coming to the Riedel's has grouped retention planning into 3 groups, that is no retention, moderate and permanent retention. Okay, so what are the cases which require no retention? Please note this listen this with utmost care, because a number of questions have been asked in your exams. So no retention required, that is natural retention in the cases of crossbites, that is anterior and posterior, dentition that have been corrected by serial extractions, Corrections achieved by retardation of maxillary growth, because once the growth is completed, it cannot begin again. Dentitions in which teeth have been separated to allow eruption of previously blocked out teeth. So once the teeth have erupted, it is not possible that teeth will go down, okay, and it will relapse. Blocked out or highly placed canines in class 1 extraction. This was part of a recent previous NEET exam in which they gave you an image and asked you, there was a image of buccally erupted canine, and the question was about this topic only, that what kind of retention planning would you do for such cases. Okay, so here I mentioned in the theoretical point, they asked you in the form of an image based question. Next, moderate retention or semi-permanent retention. In class 1 non-extraction case, which was characterized by protrusion and spacing of maxillary incisor, it is required once the normal lip and tongue function has been achieved. Next, class 1 or 2 extraction cases, okay, require the teeth to be held in contact, particularly in the maxillary arch, until lip and tongue function have achieved a satisfactory balance, as in non-extraction mode. Basically, the neuromuscular balance should have been achieved, which we have already told you before. Next, corrected deep overbites in class 1 or 2 malocclusion require retention in vertical plane. Okay, this was in the sagittal plane. Now in vertical plane, if the interiors were intruded, okay, if the deep bite correction was done through anterior intrusion. Next, if the overbite correction achieved as a result of clockwise mandibular rotation, vertical dimension should be held at least till the growth is catches up to the neurovascular balance can adapt. What it means to say that once the growth is if we have achieved the overbite correction, okay, which is through the rotation of mandible, means we have rotated the mandible backward through various means, either through eruption of the molars, okay, or through any growth appliance, okay. So retention should be there till the growth is happening, okay, so that the neuromuscles, the muscles surrounding the mandible, which are attaching it to the skull, achieve or reorganize this new position. Okay, I hope it's clear, the corrections which are done in vertical plane. Next, cases with ectopic eruption of teeth or the presence of supernumerary teeth, okay, require some semi-permanent retention. Permanent or semi-permanent retention cases are like arch expansion, okay, generalized spacing, midline diastema, severe rotations, patients exhibiting abnormal musculature or tongue habits, and lastly cleft lip or palate. Okay, midline diastema, expansion and spacing most commonly asked. Okay, rotations के case में they mostly ask about the CSF, the protocol recommended by Edwards. Okay, so I'll coming up to certain images, because a number of students asked us about to show images of from orthodontic point of view. Okay, so I'll be taking up images for this topic now. So beginning with the bonded retainers. Just a minute. Beginning with the bonded retainers, the advantage of this bonded retainer is it's permanent and it's long term. Where it is bonded, it's bonded on the lingual surfaces of incisors. It can extend from premolar to premolar, or from canine to canine, or incisor to incisor, depending upon the case. Okay, so what is important for you is that they are made up of blue alveoli wire of dimension 0.032 to 0.036 inches. Just remember this, and it was introduced in the year 1944. But today the current concept is either the use of multi-stranded wire or round stainless steel wire of this dimension. Blue alveoli wire is no longer recommended, but it was introduced with the use of blue alveoli wire. Okay, common name for this bonded retainer is FSW. So in exam they can give you a short as a short form as well. Okay, so what is the full form? Flexible spiral wire. Okay, now in exam the commonly question asked is they can give you this image. Okay, or they can give you an image of a midline diastema case, and they ask you what kind of retention will you plan for such once this midline diastema gets closed. Okay, and in option there can be a bonded retainer. So from here you know that a bonded retainer is a permanent retainer and it's for long term use. Next comes the Holly's appliance, which you have most commonly made, and everyone would have made it during your graduation, from beginning from third year to internship, PGs के cases के लिए, अपने case के लिए. Okay, so coming to the appliance, that is the Holly's appliance. So how to distinguish between a Holly's appliance which is used for retention or for active treatment? So for active treatment, there should be a space between the incisor and the margin. That is, there should be a clear margin. Why? Because once if there is a clear margin, when we'll activate by compressing the loops, the incisors will move into that space. If there is no space and we are continuously exerting force through the labial bow, extrusion will occur, because वो force कहीं ना कहीं dissipate तो होनी ही है. Okay, and once if our appliance has a scalloped margin, that is, it surrounds the teeth like this, it becomes a retentive Holly's appliance. Okay, so there is for some modifications in this Holly's appliance. It comes as a Begg's retainer, or also known as wraparound retainer. So this is an image of a Begg's retainer. Okay, so this is how it looks. So why it was introduced? Because it's mostly given in cases with we have done extraction of traces treated by extraction of premolars. Cases treated with after extraction of premolars. Why? Because in Holly's appliances, the labial will pass through the interdental space of the canine and the premolar, so it did not allow the space to remain closed, and subsequently it opened. Whereas in Beck's retainer, the labial bow is long and it passes distal to the first molar, allowing the space to get closed. Okay, next is retainer with labial bow soldered to Adams class. Less occlusal crossover wire allows better settling. Okay, for the modification of Holly's appliance only. Okay, next comes the Kessling's tooth positioner. Okay, Kessling's tooth positioner is similar to an invisible retainer. Okay, the one which we made up of similar sheet from aligners. And lastly, it's all Essex retainer. Okay, these two are a similar kind of thing, Essex retainer or invisible retainer. Here's the image. Okay, and Kessling's tooth positioner, the difference between these are, in Kessling's tooth positioner, the upper and lower retainers are joined. Okay, and minor tooth movements are possible. So how it is made? Once we debond the case, we take a impression. If there is any minor discrepancy, we correct it or reposition teeth on the plaster cast. Okay, we cut that teeth and reposition it to the newer position. Please note, only minor movement can be done through that, no major movement. Slight tipping, slight buccolingual incisal edge correction is done, and the retainer is made through these sheets, thermoplastic sheet on the new position, and the retainer is given. So what will happen? Retainer उस नई position पे force exert करके वो minor correction कर देगा. Okay, so that is the advantage of a Kessling tooth positioner. Okay. Next is a wraparound or clip-on retainer, also known as spring aligner. So what it is, it's a removable clip type retainer that controls alignment of only anterior teeth, given from canine to canine or premolar to pre. It consists of a plastic bar, which is usually wire reinforced along the labial and the lingual surface of the teeth. It's used to prevent opening of the spaces and derotation of maxillary incisors. Okay, and can be used to correct mild lower incisor crowding. So it's also known as a active retainer. Okay, so next comes retention in cases of deep bite. Okay, Deep bite, as we all know, is also known as Deckbis bite or German malocclusion. Okay, so what do we give? We give a removable maxillary retainer with an anterior bite plane. Okay, so how it helps? It helps the anterior bite plane allows the contact of the lower incisors. Okay, and there is a interocclusal space in the molar and the premolar region. So what will happen? The premolars and the molars will erupt, helps in correction or and retention of the deep bite. Next is Hawley's with anterior inclined plane. It is used to give retention after functional appliances. Okay, after functional appliances, we give Hawley's with anterior inclined plane. So how will it help? The anterior inclined plane will prevent the lower incisors to go back, and lower incisors in turn are in the mandibular bone. So it will prevent it to go back to or relapse of any class 2 tendencies. So what is the angle at which the anterior inclined plane is there? It is given at a angle of 60 degree to the occlusal plane. Next is retention after anterior open bite correction. So maxillary retainer with bite block, along with the high pole headgear. Okay. Or lastly, we can give a open bite binocular to patient for the patient to wear it at night time. Okay. So what does the bite block do? Posterior bite block impedes eruption of the premolars. So अगर premolars और molars erupt नहीं करेंगे तो anterior open bite relapse नहीं होगी. Okay. So this is a image. High pull headgear is given in cases when we have corrected the open bite using growth modification. So जब तक growth खत्म नहीं होती है, high pull headgear patient has to continue. Once it's completed, we can shift the patient to any of these appliances. Okay. Next, in retention in class 2, overcorrection or anterior inclined bite plane I have already discussed, and in class 3, functional appliance. And what is the functional appliance which is commonly given for retention of class 3 correction? Okay, that is bionator. Class 3 bionator is the appliance which is given. Okay, so this was a discussion or a session on retention and relapse. Coming to the removable appliances. Okay, so what are the advantages of a removable orthodontic appliances? It can be they are fabricated in laboratory and adjusted externally, so hence less patient time, reducing the chairside appointment. Okay, they can be removed on socially sensitive occasions. Okay, fixed appliances cannot be removed, the patient has to visit the orthodontic office. Removable appliance can be easily removed by the patient. Okay, hence this aligner treatment has came up as a boom. Okay, because of the problems with the fixed or braces. Okay, lastly, some type of growth modification or growth guidance can be carried out, which like the one which we do with twin blocks activator functional modification, which was not possible with fixed appliances. Why? Because fixed appliances were attached to the teeth. They can only carry out movements of the teeth, not of the growth or bones. So what are the disadvantages of these fixed appliances? Their response was patient dependent, highly patient compliant was required for the success of orthodontic treatment done with removable appliances. Okay, next, the wire contacts at the one surface. So it was difficult for 2-point contact. Supposedly we want rotation correction. Okay, so which was not possible. Why? Because for rotation correction, we know from biomechanics, a couple is required. Two non-collinear forces acting in opposite direction should happen. Okay, which was not possible with removable appliance. Removable appliance can have only 1-point contact. Okay, sorry. Okay, next, this is a small conversion formula. How to convert from MIL, that is MIL was a measuring system used by Britishes. So sometimes examiners ask you or they give you dimensions or the gauges of the wire in this mil. So how to convert? It's 1 by 1000 of an inch. So comes out to be 0.025 mm. Just remember this formula because a normal few questions also come up with varying the units of the SI units of the wire dimension. So next comes the two most important slides, because a number of questions are formed with. So this is the formula. Force is dependent upon the directly proportional to the fourth power of the diameter of the wire and inversely proportional to the cube of the length of the wire. So how do we vary this? If we double the diameter of wire, increases the strength by 8 times and decreases the springiness by a factor of 16 times and decreases range by a factor of 2. So strength, please note first of all this is diameter not radius. So sometimes examiner में हमेशा कभी कभार रेडियस भी मेंशन कर देता है. तो एज वी ऑल नो रेडियस इज डायमीटर डिवाइडेड बाय 2. ओके, अगर वो वैल्यूज़ फिगर्स में बात करेगा तो आपको ये कन्वर्जन ध्यान रखना है. ओके, सो हाउ डज द स्ट्रेंथ वेरीज? स्ट्रेंथ वेरीज डायरेक्टली विद द डायमीटर. अगर हम डायमीटर ट्वाइस कर देंगे, स्ट्रेंथ 8 टाइम्स बढ़ जाएगी, फोर्थ पावर. स्प्रिंगनेस क्या होगा? डिक्रीज हो जाएगी बाय 1/16 एंड रेंज हाफ हो जाएगी. ओके, here D stands for the diameter. प्लीज़ ये बिल्कुल ध्यान रखना. स्ट्रेंथ, स्प्रिंगनेस इज मीन्स फ्लेक्सिबिलिटी एंड रेंज. ओके, बिकॉज n नंबर ऑफ टाइम ये क्वेश्चंस पूछे गए हैं. हाउ डज इट वेरी विद द लेंथ? सो स्ट्रेंथ लेंथ के हिसाब से अगर ट्वाइस की जाएगी तो स्ट्रेंथ हाफ हो जाएगी. स्प्रिंगनेस 8 टाइम्स बढ़ जाती है एंड रेंज इंक्रीज बाय 4 टाइम्स. ओके, तो स्प्रिंगीनेस को दे कैन कंप्यूट एज फ्लेक्सिबिलिटी एज वेल इन द एग्जाम. ओके, एंड स्ट्रेंथ में दे कैन राइट इट एज, जस्ट टू कंफ्यूज और स्टूडेंट्स, बेंडिंग स्ट्रेंथ या टॉर्शनल स्ट्रेंथ. हाउ विल इट वेरी? सब अगर डायमीटर ट्वाइस कर दिया, 3 टाइम्स कर दिया. ओके, सो जस्ट रिमेंबर दिस फॉर्मूला एंड दीज टर्म्स. So this is how we do it clinically in patients. How do we increase the length? We incorporate loops into the wire. Okay, so as to increase the length of the wire. So a small question: anchorage in a removable appliance is provided by. Okay, the options are label bow, finger spring, finger acrylic plates, clasp, or both C and D. So anchorage in a removable appliance is always provided by acrylic plates. Okay, label bow can be a retentive or active component. Finger spring is an active component. Clasp is a retentive component. Acrylic plate provides anchorage. Okay, so what are the 3 components of a removable appliances? These are the retentive components, which is by clasp, active components by bows or springs, anchoring unit of base plate pipe, which is formed of the cold or heat cure acrylic, provides the anchorage unit. So we'll discuss each of these components and what are the various things which are due. So beginning with the first, that is the retentive components. Retentive components are the circumferential clasp or the C clasp, further modified into the Jackson's clasp, full clasp or a U clasp, Adams clasp, most commonly used, and which you have all made during your graduation BTS time. So it is also known as a Liverpool clasp or a universal clasp or a modified arrowhead clasp, which is constructed using 0.7 mm SS wire. Okay, length is 2/3 the mesodistal dimension width of the distance between the buccal cusp tips. Okay, bridge is at angle of 45 degree to the tooth surface. Okay, it can be modified to single arrowhead or a double arrowhead depending on the requirements. Next is south end clasp, also known as Stephen's clasp. Please note, because it was given by Stephen, it is used for retention in the anterior region. Okay, these are the images. This is the south end clasp. Okay, these are the C clasp, U clasp. Okay, modified Adams clasp in which helix was incorporated. Okay, or a pin soldered hook is incorporated, and lastly the triangular head clasp. Triangular clasp I have just shown you. Ball end clasp, okay, used to engage the proximal contact of posterior teeth. Schwartz clasp or a arrowhead clasp, it was a predecessor of Adams clasp, can be used in deciduous or permanent teeth. I'll just show you the image. So this is the Schwartz class. See the loops which are present. Okay. And lastly, the crozet class. It resembles a full class but has an additional piece of wire which engages into the mesial and proximal undercuts. It provides better retention than full class. So this is the crozet class. Okay, it has additional pieces of wire, so it just engages the. So this is the additional wire which is engaging the mesial and distal undercuts. Okay. This was the active components. Next comes the, this was the retentive components. We come to the label bows. So what are the common modifications? Commonly used are the short label bow, the long label bow, split label bow, reverse label bow, or the high label bow. Okay, high label bow short समझ सकते हैं हम from canine to canine. Long is from premolar to premolar, 4 to 4, or अगर if there is extraction case from 5 to 5, from second to second. Split label bow is the one which is cut into the middle for closure of midline diastema. Reverse label bow, I'll just show you the image. So this is the reverse, the loops are reverse. This is a reverse label bow. Okay, what is the advantage of reverse label bow? It is used for retracting the anterior proclined anterior teeth. Next is the high label bow. High label bow means the label bow, the air bridge is present more apically. So what is the advantage? It is for carrying apparent springs for retraction of teeth with large overjet. I'll just show you. This is an image. This is a split label bow. I have an image for this. I'll just show you. Oh, this is the high label bow with apparent spring attached. So see, it's in the buccal vestibule, and this is the spring which is attached to it. Spring is made up of light dimension wire, so it provides stability to that spring. We'll come to that part of springs in the later slides. Next is the Roberts retractor. It is made up of thin gauge SS wire with a coil of 3 mm diameter. Okay, so why it's used? It's used for retracting posterior teeth which are severely proclined in sizes of overjet of greater than 4 mm. Next is Mills retractor with label bow having extensive looping of the wire so as to increase the flexibility and range of action. It is indicated in patients with large overjet. So this is the Mills retractor, image of a Mills retractor, and this is the Roberts retractor. See the incorporation of helix in it, loops in it. So what does it do? It increases the range and flexibility. So in severely proclined teeth with overjet of greater than 4 mm, these are used. And fitted label bow. So this is a fitted label bow. See how it's surrounding the margins. Okay, so these are the images I've just shown you of the bows. Next comes the springs. Springs are of various types. First, the self-supported spring. So सेल्फ सपोर्ट है मीन्स उसको कोई सपोर्ट की ज़रूरत नहीं है. ऐसे वही स्प्रिंग हो सकते हैं जो थिक वायर से बने. ओके, सो कॉमन एग्जांपल्स आर द बकल कैनाइन रिट्रैक्टर्स, द यू लूप कैनाइन रिट्रैक्शन, कॉफिन स्प्रिंग, हेलिकल लूप कैनाइन रिट्रैक्टर, एंड दे हैव अ स्टेबिलिटी रेशियो ऑफ 1. व्हाट इज स्टेबिलिटी रेशियो? आई विल कम टू दैट. सपोर्टेड स्प्रिंग, सो जो सपोर्ट चाहिए जिनको, वो सपोर्ट क्यों चाहिए? तो वायर थिन डायमीटर की है, दैट्स व्हाई दे रिक्वायर सपोर्ट. ओके, so that's the one which I showed you here. So how do they require, how the support can be given? Through a guided wire, or they can be additionally put in a box of acrylic to ensure adequate stability, वरना वो अपनी जगह से हिल जाएंगे. Next come the guided springs, that is the cantilever springs, finger spring, T spring, palatal canine retractor, and auxiliary springs, that is the apparent spring. So this is the apparent spring, which is also a supported spring. And guided spring are the cantilever springs, can be single or double cantilever. Common example being the Z spring, okay, the finger spring. I'll just show you the images of all these in upcoming slides. So what are the requirements or ideal requirements of a spring? They should apply force of required magnitude. ठीक है, force should be in the required direction. Be robust, that is easy to make. Be stable, that is just not slip from the desired position. If it slips, the desired movement won't be carried out. and should move the teeth through the required distance. So what are the common springs? Beginning with the first one, that is the finger spring. ठीक है, इसका अदर नेम क्या है? दैट इज द सिंगल कैंटिलीवर स्प्रिंग मेड अप ऑफ डायमीटर ऑफ 0.5 to 0.6 mm वायर. It is used for mesiodistal movement of the teeth. Okay, the direction of the coil is opposite to the intended direction of the movement. Width of the coil is approximately 3 mm or 1/8 of an inch, and it's unsuitable for buccally placed teeth. Next is the Z spring or the double cantilever spring, used for the movement of labial movement of anterior teeth. तो यहाँ से हेलाक्स खोलेंगे तो it will happen this. Okay, and it is you can be used for minor rotation correction as well. They have two coils, should be perpendicular to the palatal surface and activated by opening the helices. अगर हमें प्रॉपर टिपिंग चाहिए, लेबियल मूवमेंट चाहिए, तो बोथ हेलाइसेस शुड बी ओपन. अगर हम एक ही हेलिक्स ओपन कर रहे हैं, ओनली रोटेशन करेक्शन कैन बी. इसका अदर मॉडिफिकेशन इज द एम स्प्रिंग और विच इज यूज फॉर करेक्शन ऑफ midline diastema. Next is the matrix spring. Okay, this is the image of a matrix spring. So another question for you, Adams class for molar is made up of. So the options, the units as I've told you was given in mil or the MIL system. So the correct answer is D, that is 28 mil. So how to convert from mil to inch, I have already told you. So another conversion from MIL to gauge is you divide the value by 4, okay, and subtract 7 for it. Okay, so for here 28 divided by 4 is 7, and if we subtract that value from 29, we get the gauge of that value. Okay, so from MIL to gauge conversion is divide by 4, the whatever the value, x value, divided by 4, and then subtract that value from 29. That is the formula which you get. Next comes the stability of the spring. So how to improve the stability कि वो अपनी जगह पर है. Okay, how it can be done? Guarding with the wire. So how what we have seen, what is the guarding of the wire? We can surround the spring on a heavy wire. Like ये labial bow, high labial bow बना है with a thicker dimension wire. We wrap the spring around it. So it improved its stability. Because spring is made up of a lighter dimension wire. On next, we can protect the spring with acrylic, and where it is done, we do it in the cases of Z spring. उसको एक box of acrylic में हम place कर देते हैं. Okay, so that it does not get distorted due to the occlusal forces. Okay, so next comes the spring should be guided so that its action is exerted only the appropriate direction. Okay, अगर हमें लेबियल मूवमेंट करानी है इंसाइजर की, इट शुड बी गाइडेड. मतलब वो लेबियल या पैलेटल सरफेस पे उस तरह से पोजिशन होना चाहिए दैट इट कैरीज आउट दैट इंटर्नेड मूवमेंट. सो हाउ टू वी डू दैट? वी प्लेस द स्प्रिंग इन द अंडर कट ऑफ द टूथ सो दैट इट डज नॉट स्प्लिप ऑक्लूजली ड्यूरिंग एक्टिवेशन. ओके, हमने स्प्रिंग का हेलेक्स ओपन किए, द आर्म्स स्लिप्स ऑक्लूजली, देन इट वोंट बी एबल टू कैरी इट आउट दैट मूवमेंट. We can use a guide to hold the spring in its position. I have already told you how. Or we can bond an attachment to the tooth surface to engage the spring. Okay, it's really done now. So what is a stability ratio? This is a formula which should remember. That is stiffness in direction of unwanted movement divided by stiffness in intended direction of movement. So in practice, or for you to remember, the stability ratio of the finger spring has the highest, and it is lowest for the buccal canine retractor. Okay, so further some images. The first is the image of a ballista spring. It is used for the eruption of a impacted canine. This spring is made like this. It is brought and engaged with this impacted canine. So what will happen? Spring की tendency होगी to go back. Okay, and it will take the canine or erupt the canine along with it. Okay, and next is the whip spring, which is used for correction of rotation. Okay, using removable appliances. Whip spring, and these are rarely used now. Okay, ballista spring is still used, but rarely, mostly in academic colleges. So this is just a summary of the gauges or the dimension wire used. I have summarized them in a table. If you can remember one dimension, my recommendation, just remember one, and do the conversion. If you remember all three, well, good, saves your time. Okay, this is a summary of the table for retractors. Okay, and lastly the conversion table from mm to gauge to L. So coming to the last few slides of about, we'll just quickly go through what the canine retractors. So they are classified into three types. First, based on location, they can be buccally or lingually placed. Based on the presence of helix or a loop, canine retractors with or without helix. And lastly, based on the mode of action, it can be push or pull type. So firstly is the U-loop canine retractor. It is made of 0.6 to 0.7 wire. Okay, it's U-loop. This is the image of a U-loop canine retractor as an active arm and a retentive arm. Okay, so this is the retentive arm. This will be the active arm. How does it retract? We just close this loop, okay, and it will bring the canine along with it. So the mesial end is arched around the canine below its mesial contact point. Least effective gives minimal retraction of 1 to 2 mm is required. How it's activated? It's activated by closing the loops by 1 to 2 mm or cutting the free ends of the active arm by 2 mm and readapting it. Its ease of application and is less bulky. Next is the helical loop canine retractor. Okay, also known as reverse loop canine retractor, made up of dimension of 0.6 mm. Okay, a coil of 3 mm diameter, an active arm distal and retentive arm is there. Okay, so what it does is mesial arm is adapted between the premolars for retention and the distal arm is active, which engages the canine. In these loops, the most common thing or the thing which should know is the diameter and the position of the active and the retentive arm, where its position. Then only you are able to distinguish the loops. Okay, the distal arm engages the canine and the coil is placed 3 to 4 mm below the gingival margin. So how it's done? Activated by opening the helix by 2 mm or cutting the 2 mm of the free end and readapting it around the canine. It's indicated in shallow sulcus and in mandibular arch. Next is buccal self-supported canine retractor, made up of 0.7 mm diameter, consists of helix of 3 mm diameter with an active and a retentive arm. The coil is placed distal to the long axis of the canine, and the active arm is mesial and retentive arm is distal. It is indicated in buccally placed canines or highly placed canine in the vestibules. Why it's called self-supported? Because it is made of a thicker dimension wire which can resist distortion. And now it's activated by closing the helix. Helical canine was activated by opening the helix, and this is activated by closing the helix. Next is the palatal canine retractor. It's made up of 0.6 mm wire diameter wire. It's generally enclosed in acrylic box on the palatal surface. It consists of a 3 mm diameter of active wire. Active arm is placed mesial to the canine and helix is placed along the long axis of the canine. So indicated in the retraction of canine that are palatally placed. And the activation is done by opening the helix 2 mm at a time. So how to remember a small mnemonic, that is HOP. Helical and binary retractors are activated by opening the loop. Okay, and UCB, that is U loop, and buccal self-supported canine retractors are activated by closing the loop. So just remember these two, HOP and UCB. Okay, so I hope that today's session was informative and it contains a lot of images, okay, which is useful for your NEET and INA exams. Okay, still there's a lot of things which needs to be covered on these topics, but in the allocated time we can only cover this much. Okay, so thank you so much for listening. If there is any queries, you can tag me on the Facebook, okay, club, which is the DAMS MDA Squares Club, or you can mention in the chat box here. I'll be happy to answer them, or you can send me on a WhatsApp group as well. Okay, so thank you so much for listening to me on the festival day as well.